So for the neuromuscular junction blocking agents, there are two main things you need to realize. There's two main classes here. You have a depolarizing and a non-depolarizing. The non-depolarizing, they achieve their blockade by physically limiting the access of the agonist to the receptor. So it functions as kind of as a competitive antagonist, is a good way to think about it. Now, the depolarizing agents, they achieve their blockade of the neuromuscular junction over activation. That's a big word. You need to remember that. Activation of the normal agonist pathways. That's very weird. There's only one depolarizing neuromuscular junction blocking agent, and that's succinylcholine. So you better believe they're going to ask you about that one. Succinylcholine. He is the only depolarizing neuromuscular junction blocking agent. But there's two classes, non-depolarizing and depolarizing. Alright, so there's something really weird with succinylcholine, and that's the depolarizing agent here. You need to know there's two phases. I don't know how high yield this is, but I want you to know it anyway. So phase 1 block is the depolarizing phase. So basically what that means is you depolarize the membrane. The succinylcholine will bind to the receptor, the membrane. It causes an initial discharge that will produce like a fasciculation, if you will, followed by what? A flaccid paralysis. That's why we use it in surgery. So, but because succinylcholine is metabolized so slowly, the membrane becomes what? Unresponsive to further impulses. So it can keep hitting it, but it ain't going to do anything. But then you got a phase 2. This is the desensitizing phase. After we keep repolarizing, this unresponsive, then we go into phase 2. In phase 2, you eventually repolarize the membrane. Now, however, it still remains unresponsive. Still unresponsive, even though it's repolarizing, it's desensitized. That's the desensitized phase. Now, during the very late stages of phase 2, you can actually have reversal by some acetylcholine esterase inhibitors. But it's not till the end. So if you're going to use succinylcholine, you're going to be depolarizing that membrane for quite a while, and it's got two phases of blocking the membrane. Now the non-depolarizing agents, we got a couple of them. We got d-Tubocurarine, Atracurium, Rocuronium, Mivacurium, and Mivacurium. All these are competitive antagonists of acetylcholine at the nicotinic or muscarinic receptor. What do you think? At the nicotinic receptor. Nicotinic receptor. Now, we're not talking about muscarinics here. We're talking about neuromuscular junction blockades. Anything neuromuscular is always nicotinic. So these are the 5 drugs that we're going to be talking about a little bit here. So let's talk about d-Tubocurarine. This is the prototypical non-depolarizing agent. Use this because of it has a very long duration of action. It's useful in surgical paralysis. Has been used. There's newer agents. The adverse effects is it causes a weak muscarinic acetylcholine antagonism and some histamine release. So side effects. So yeah, you can have a little histamine release and also, what was it, some anticholinergic effects here. With d-Tubocurarine. Now, moving on to Atracurium. This drug right here is very, very similar to d-Tubocurarine in duration and activity, but it does not have histamine problems or anticholinergic problems. So the main thing you need to remember about this guy is he is the drug of choice for renal transplantation. And why do you think that would be? Why do you think he would be the drug of choice for renal transplantation? It's because Atracurium is eliminated by ester hydrolysis. That's what makes it the drug of choice in renal transplantation. So it's actually the ester hydrolysis that allows this guy to be the drug of choice. Now, Rocuronium, it's useful in patients with also renal impairment. Because why? It's got hepatic excretion. So, this is a Rocuronium is a 20 to 40 minute duration drug, and it's very, very useful for surgical procedures. Now, moving right along to Mivacurium. This is an intermediate duration of activity. They also can use this. This is intermediate duration. Now, what's the difference between Rocuronium, Mivacurium, and Mivacurium? Mivacurium has a rapid onset with a long or short duration of activity. I'm going to guess short because it's rapid. It's going to be short duration of activity. So what do I mean by short? I'm talking like 10 to 20 minutes. So that's the difference between Mivacurium, Mivacurium, and Rocuronium. Rocuronium is the hepatic, that would make sense too, right? It's hepatically excreted. It takes forever to get out of there. Mivacurium is intermediate, so if you got a surgery lasting, about an hour or two, you might want to use Mivacurium. But Mivacurium, that's going to be a really rapid surgery and a really rapid acting drug. So what metabolizes Mivacurium? Plasma choline esterase is what metabolizes this plasma. Now, because the non-depolarizing agents are competitive antagonists of the acetylcholine receptor, their effects can be reversed by what? There's two drugs that you need to know. That's neostigmine and pyridostigmine. These are acetylcholine esterase inhibitors. So I would know these two. Neostigmine and pyridostigmine. Okay, so what about neostigmine? What do we know about that? Is that a tertiary or quaternary amine? That's a quaternary amine. He cannot cross the blood-brain barrier. We already know this. Cannot cross the blood-brain barrier. So by interfering with the breakdown of acetylcholine, neostigmine indirectly stimulates both nicotinic and muscarinic receptors. Indirectly stimulates nicotinic and muscarinic receptors. Now I'm going to read to you just a little bit here. You got some clinical use. Unlike physiostigmine, neostigmine is a quaternary nitrogen, hence it's more polar, so it can't enter the CNS. We know this, but it's got some clinical uses here. You can use it to improve muscle tone in people like maybe with myasthenia gravis, and as we have said routinely, in anesthesia to reverse the effects of the depolarizing or the non-depolarizing muscular relaxants. I hope you said non-depolarizing muscle relaxants such as Rocuronium, Mivacurium, Mivacurium, which is hardly ever going to be used. It can also be used for urinary retention. Resulting from general anesthesia, and to treat, I don't even know what this is, but just in case you ever see this, curiform toxicity. There's also a syndrome here, pretty cool syndrome, called Ogalov syndrome. Ogilvie syndrome. Ogalov syndrome is basically when you have a pseudo obstruction of the colon in a critically ill patient. That's another time you can use neostigmine if you want to impress your attending. So, pseudo obstruction of the colon in a critically ill patient. Now, what about pyridostigmine? What do we know about it? Pyridostigmine has some pretty cool uses. Remember in the Gulf War when you had the Gulf War syndrome? So we would use pyridostigmine bromide. It was implicated as a causal factor in the Gulf War syndrome. But we can also use this to treat orthostatic hypotension, along with reversing acetylcholine esterase inhibitors. So neostigmine, pyridostigmine, two very cool drugs. You can also use pyridostigmine off-label for postural tachycardia syndrome, and that's about it. That sums that up.